I would like to start off by asking a simple question. Does anyone know who these three ladies are and what do they have in common? Well, obviously PMS, but the first one was in 1980. Sandy was a East London in the United Kingdom barmaid with 45 previous convictions, stabbed a co-worker to death. Second one is Mrs. Christine English, also in the United Kingdom. After a quarrel with her lover, she actually crushed him to death against the utility pole. And Shirley Santos in 1981 was badly assaulted her own 4-year-old daughter. After the long preceding law case, they all got a probation sentence, 12-month driving ban after crushing someone, and the plea bargain changed to harassment. All of them, because of a conviction, changed on the basis that they all had PMS. Mrs. Sandy got married and then 1 year later attempted to murder a policeman and 3 other grievously bodily assault charges, again was released on the fact that she had PMS at the time. So we'll be talking about premenstrual disorder and the hot topic that it is at the moment. And the basics that we'll be covering is the definition, the background, pathogenesis, diagnosis, and treatment. Now, although there's not much academics behind the topic, I've tried to keep it as informal as possible and some information in between. Premenstrual syndrome, there's actually no universal definition for it, but it's good to summarize it to say that there's a recurrent physical and behavioral changes, that's symptoms that occur in the luteal phase, and this is where it gets very important. They all resolve with or directly after the onset of menstruation. Premenstrual dysphoric disorder is a subcategory, or some people say a completely different disease, but it's the exact same symptoms, but where anger, irritability, and tension are very prominent. Now, the history starts with this handsome young fellow who's called Mrs. Pliny the Elder. Now, he was a Greek philosopher who stayed under this beautiful mountain called Mountain Vesuvius. And he actually died when this thing erupted. But he also has made a few very interesting comments in life, of which, in the matter, the only certainty is that nothing is certain. Home is where the heart is. The glory consists in doing what deserves to be written and writing what deserves to be read. And the happier the moment, the shorter. So he seems like a pretty intelligent man who said some beautiful things in his life. He also said the following: contact with the monthly flux of women turns new wine sour, makes crops wither, kills grafts, dries seeds of gardens, etc., rusts metal, and makes dogs mad. So this was his conviction, and based on that, the whole medicine fraternity started describing anything that has to do with females that they couldn't understand towards the uterus and hysteria. And it ranged anything from migraines down to extraordinary genital excitement, all the way down to homicide. And the treatment was just as bizarre, with leeching and blistering as possible causes. So finally we reached some sanity when this beautiful young lady, Mrs. Karen Horney, was the first female psychologist, published this article in the 1930s, where she described the symptoms occurring recurrently in the luteal phase of the menstrual cycle. And this gentleman, Dr. Robert Frank, the first ever medicine person to describe hormonal changes to the premenstrual tension syndrome. So that's when we get to our actual disease. We know that there is some risk factors associated with any disorder out there. The first is to notice that there is a very strong link in genetics with premenstrual syndrome. In fact, there's one randomized trial that shows that if your mother or direct relative had premenstrual syndrome, you will have a 40% more likely chance of developing the syndrome yourself. There's a study with monochorionic and monozygotic twins that show that the babies with monozygosity will have a 4-fold increased risk above those that are dizygotic. The other risk factors, lower education, smoking, history of a traumatic disease, event, anxiety disorders, and daily hassle scores, all boil down to a certain type of phenotype of patient. The pathogenesis then, as we know it's linked to the menstrual cycle, you can deduce that ovarian steroids will play an important role. Now, important to note that always these patients have normal levels of estrogen and progesterone. It seems that they just have a greater response to them. And that was published in this little article. Now, I know the numbers are extremely small, but it does illustrate the point very well. And numbers small, I mean with 10 patients. But what they did is they gave the patients leuprolide, which is an GnRH analog, and that actually showed that in premenstrual women and normal women, if you give them the GnRH analog, they have lower levels of sadness, and this is just one example, but all the graphs look exactly the same. If you then go and add back estrogen or progesterone, the symptoms recur in the premenstrual syndrome group, and the normal women will have normal symptoms. So this clearly illustrated that these patients have an abnormal response to normal hormonal levels. But why? And the key comes in the neurotransmitters, of which the main culprit is serotonin. We know that patients that suffer from premenstrual syndrome and premenstrual dysphoric disorder have lower levels of SSRI in the serum as well as the platelets. And we also know from therapeutic trials that SSRIs are the best form of treatment. We also then did the converse and gave them metroglycine, which is an SSRI antagonist, and showed that the symptoms recur. The vitamins and minerals and the pathogenesis I'll come back with during the treatment. So the diagnosis. Simple, it sounds, but actually very complicated. A good clinical menstrual history is of vital importance. It's important to note that the history should be taken in the future and not as a retrospective. Because as soon as you include retrospective data, your diagnostic sensitivity falls to less than 50%. A good clinical exam to exclude other conditions, of course, thyroid conditions, major depressive disorder, the thymic disorders, and oral contraceptive use. Then there's a scoring system. And the scoring system is used to get this menstrual history and to quantify the symptoms the patient feels. But it's important that all of them include that it impairs the woman's functioning. Of course, now, like Dr. Thomas Singh has alluded to, the DSM-5 has now included the premenstrual dysphoric disorder as an official diagnosis. So this is what the graph looked like. I know it's extremely small, but that's why I used it to show you how ridiculous it is. And it's got all kinds of things: felt angry, irritable, couldn't sleep, sleep too much, sleep too little, every basic syndrome. In fact, there's more than 200 in the list. So I made a small prospective study with a complete value of 3. I had complete uninformed consent with no ethical approval, and the questionnaire, the patients will see the results now. All 3 of them were asked the questions based on the above. And all 3, in fact, Neil has qualified the best as premenstrual syndrome. I think you will all know why. And so this illustrates the point very clearly, that those questionnaires are not to be used as a diagnostic screen, because these symptoms are not, some of them are not interfering with daily living, and some of them are obviously not true. So let's get to treatment. If I said that ovarian steroids play a very important role, it's important to then realistically say that ovulation suppression will be the baseline of treatment. In the past, we used to just give these patients oral contraceptives thinking that it will work well, but in fact it does the opposite. Their mood symptoms, their physical symptoms like the bloating and the breast tenderness does improve, but their other symptoms does not. The only new kid on the block is the drospiridone-containing anti-ovulation suppression treatment in the form of Yaz and Yasmin, which is now, according to the Royal College, the first-line treatment of premenstrual syndrome. There is some, however, people that do treat this with GnRH analogs to try and get complete, but as you know, that giving these drugs are completely toxic to the body and will actually induce a menopausal state and is not for long-term use. Surgical castration has been actually used in the past, and it's reserved for those patients that have intractable symptoms, and usually recovery is quite well. The second step, as we alluded to in the pathophysiology, is the neurotransmissions. And here, like I said, the Royal College also says SSRI is the first line of treatment in this division. They can use this, interestingly enough, as a continuous dose or only during the luteal phase. And they say that these patients have immediate response after the first tablet. Benzodiazepines, the long-acting, has been used, although there's dependency-like symptoms. So buspirone is a benzo-like derivative with no addictive potential that can be considered in cases not responsive to SSRIs. Diagnosis and counseling is actually the first step in this. They've shown in randomized studies that patients that were not aware, and they're using population groups like Brazil and Central Africa, that were not aware of the diagnosis of PMS, did, however, conform to the diagnosis. But in the European Union, where everyone knows the diagnosis, 90% of females screen positive on their own. But if you then exclude them based on strict criteria, only 2%, the standard for population, will have premenstrual syndrome. Explaining the diagnosis to her and using a form of cognitive-based therapy, most patients will do better. Exercise has been helpful, but never studied formally and never proven. Diet is a big controversial subject, giving the patients low-fat diet, low-carb, high-protein. Every single definition has been tried, but none of them have shown effective. And I would like to stop and just show you something about vitamin B6. A lot of publications on the use of vitamin B6, calcium, and magnesium, which contradicts itself. But B6 is a tryptophan metabolism cofactor into serotonin and dopamine, and that's why they postulated it might work. The usual dose is 50 to 100 milligrams 3 times a day, or daily to 3 times a day. But of note, patients can get irreversible toxicity with doses as high as 50 milligrams. So be careful in prescribing over-the-counter, and especially these herbal medications containing high doses of vitamin B6, because the toxic dose is quite narrow therapeutic index. Since it's now stuck. So in summary, it's a common disorder, but it's heavily over-reported, especially in the affluent communities. It's a difficult management as there's no clear pathophysiology, and as anovulation and SSRIs are usually the main options. Diet, exercise, and herbal interventions have showed little or no effect. In fact, I wanted to say here that the placebo effect in any trial concerning PMS was up to 30%. Where most of these ranged in the 20-30% effect. So they're actually worse off than placebos. And DSM-4/5 should be used ideally with a help of psychiatric assessment for premenstrual dysphoric syndrome. That's it. Okay. Yes, something interesting that I've read about this is the screening factors. Is something to ask them is if they had postpartum depression. Because if they were diagnosed with postpartum depression, they have a more than 90% likelihood of developing PMS later in their life. And that they say that patients that have developed postpartum depression, it's actually indicated to start them on treatment irrespective of symptoms, because they will develop it later on in life. And we see them, definitely.
The reason I'm asking, even among ourselves as colleagues, the symptoms might be there, but must be at the level of work or the environment where we work. If you're working in the office, you'll be filming and telling people to get off and say, no, it's just a PMS. But here you say, no, it's working way more. So perhaps, yes, believe that I see traces in others.
Well, you screen positive, so.
Any